Deep in the heart of Texas is a place where heroes gather and where hope is growing. This place is Fort Hood, Texas. At first hearing the words Fort Hood, most people think of the massacre inflicted by Nadal Malik Hassan in 2009. However, this horrific event does not define Fort Hood, and we at the Institute have heard many amazing stories of the heroes and hope found in Texas Hill Country. New hope for those that suffer from post-traumatic stress is offered at the Warrior Combat Stress Reset Program at the Carl R. Denal Medical Center. This 11-week intensive outpatient treatment program is led by Dr. Jerry Wesch and has been touted as highly successful and emulated on other bases across the United States. The success of this program is in large part due to incorporating mind, body, and complementary alternative medicine approaches for the treatment of moderate to severe combat-related post-traumatic stress symptoms. The program consists of a 3-week Jumpstart treatment program during which soldiers report to the WCSRP for duty each day, followed by 8 weeks of individualized follow-up therapy. I am pleased to have been welcomed onto the base to get an up-close look at the formula they utilize to help these heroic combat veterans find a sense of wholeness in their lives once again.
Well, this program began actually with an idea borrowed from Fort Bliss in 2007. Fort Bliss had started a similar kind of program, a holistic program in their Warrior Transition Unit the year or so before. And my colleague down there had started a holistic program using complementary therapies and a lot of psychological work inside the Warrior Transition Unit, which is essentially an Army rehabilitation camp. And it got a lot of publicity. They produced some really good results. And so all of a sudden everybody wanted one, and so they started the task of standing up a comprehensive program for PTSD here at Fort Hood. There was a task force that worked throughout 2007 and a lot of 2008. They put up the building and designed the building for the program, and we looked at, essentially we reviewed the whole literature on PTSD and PTSD treatment that was available at the time to see what kind of an intensive program looked like it had the best chance of producing, because the charge really was to produce the most effective PTSD program that could be made. So we went at it using an older model from the grandfather of behavior therapy, Dr. Arnold Lazarus, who was a prime theorist and teacher in psychology in the 60s, 70s, and 80s. He had a very long and illustrious career. And he said, when you're going to treat any complicated disorder, start with dismantling it into components and then put a treatment piece in your protocol for each one of those components. So we started with an emerging description of what at that time was called complex PTSD, which seemed to fit what you see in combat soldiers better than the basic description from 1980 DSM-3, DSM-4. So when we dismantled that, we decided that hyperarousal probably would be the guts of combat soldiers' PTSD. They almost all are hyperaroused. They have high heart rates, they have braced muscles, they have gritted teeth, they have sleep disturbance, they can't relax, their brain idling frequency is too high, their resting alpha state is above 10 hertz where it shouldn't be. It should be 8, and we often see it at 13 to 15. They just go around all the time, they just can't relax. So once we started with that, said, okay, what can we do that would tackle that, because the first component that you can get at appears to be the inability to relax. It makes them easy to set off. It makes them easy to, impossible to sleep. It really accounts for a lot of the background. And the evolution of symptoms over time. And so we decided that we would use both self-regulation techniques like biofeedback and breathing and relaxation and yoga and meditation, as well as external techniques like massage, acupuncture, Reiki, reflexology, to really attack that hyperarousal, the autonomic system, to get it back to idle and relax again. Then, once you have achieved that, then you can go at the other components within the PTSD triad of hyperarousal and hypervigilance that goes with that, the avoidance behaviors, and then the intrusive memories. That's sort of the three legs of the stool. But if you get control of the hyperarousal first, your patient is much more likely to be willing to go work on the hyperarousal and the avoidance behaviors, because they can feel safer, that they have some control, and you've restored what in the literature would be called self-efficacy, a sense of confidence in yourself to manage. Because one of the biggest problems for folks is that when they get triggered, they go into a situation where there's a noise, a sound, a smell, a sight, an association of some kind that sets off their triggering mechanisms, and they go into a panic or hyperarousal or jumpy reactive state. It's automatic because it's like a conditioned response, and they feel crazy, they feel out of control, they feel embarrassed. The fear is really a panic attack in some cases. So they have to not go there. They stay out of those situations as best they can, and that may constrict your life down to pretty limited. One guy I know had lived in a trailer house in the woods in Alaska for 10 years after Desert Storm. He was not coming out of there. He couldn't. He felt like he would panic if he was on the road, if he was in a crowd, all the usual places that people avoid. So we laid our groundwork. We created this multimodal, comprehensive approach that would mix psychological techniques, self-regulation, mind-body techniques, with the complementary and alternative medicine modalities. And we picked those based on the experience that they'd had at Fort Bliss, as well as experience from the civilian literature on integrative medicine programs. So we stood the place up in August 2008. Our first 6 months, we did not have the complementary and alternative medicine people in place. And that's important, because when you look at our longitudinal data, we began keeping research quality program evaluation data from patient number one. And so I've got files and files and files and files. Now they're all in a computer, but we know these guys and their status when we evaluate them when they're referred, when they enter the program day one, when they leave the program after 3 weeks, and then at every follow-up point that we can catch them. So when you look at our data on that first 6 months, we produced very little change using primarily just the psychological techniques and some of the mind-body stuff. We learned something from that, and then we got our CAM contract in place, and we began doing acupuncture and massage and Reiki and all of these, and all of the modalities. And our effectiveness jumped into the statistical significant level, almost clinically significant in terms of what you usually expect. We got about 6 points of drop in PTSD symptoms. Every time we hit a turning point in the program, usually in about Thanksgiving, we go over all of the data for the previous year, look at what's working, what's changed, what our patient satisfaction data and their evaluation of us says. and then we adjust. And then so we adjusted again, and we got a bigger change in PTSD. The next year we made another adjustment in the intensity of what we did, and we got another bigger drop, so that our impact, the power and effectiveness of what we're doing has gotten bigger each year. At this point, we're producing about a 15-point drop in PTSD, so that over half of our soldiers by the end of 3 weeks score below the usual threshold for diagnosing PTSD. We're really bringing people down a lot. Soldiers love us. We have huge loyalty in the guys who are here. Our graduates would all come work for me, if they could. And a lot of them are tremendously better. I do not know at times how to explain how much better people are.
Is there any initial resistance, do you find, to coming in? I'm sure these big tough guys want to come in and do some Reiki and some Tai Chi.
Well, we're actually pretty good at educating people now about how this works. There are times when I'll bring in a senior, a senior NCO who's been through the program, and sit down and give the word to the new guys who've come in, and they'll say, "This works. Got to give it your own. Put your heart in it. Get busy." But I mean, we've had some funny scenes here. We had a big old infantryman in the corner of my big conference room doing yoga, right, on a bright pink yoga mat, and he is both he's doing a yoga stretch pose with one arm, and on the other arm he's giving the finger to the rest of the guys, and he says, "If you laugh at cuss word, laugh at me, I'll kill you. This is helping my back." And he's very, and we get that. You have to educate people. I think by the end of the first 4 days, they're believers. Okay? Just in this group, we had a guy who's had headaches since a couple of deployments ago. And he went to acupuncture. They put a bunch of needles in him, put some electricity through part of him, and he come off the table and had a headache for the first time in years. And the minute he tells that to the group, all of a sudden, everybody wants to be needled, right? And we're over the hump of belief. We tell them everything here is purpose selected. Everything that we do here has a function in their recovery. Day one, you have to decide by the third day that you're here whether this is the place you need to be. If you can get over your stigma, if you can get over your embarrassment about having PTSD, if you can get over your disbelief, and you can begin to see possibilities for yourself of going back to a life worth having, then give up your resistance and put your heart in it. And soldiers understand what that means. They've been in trainings where if you don't put your heart in it, you ain't gonna learn anything. And so if we can get them over that hump.
Do you have a probably low dropout rate, I would suspect?
Almost zero.
Yeah.
The biggest thing where people drop out is if they have life intrudes.
Yeah.
They have a kid get sick, or they have some other intrusion where their mind is not in the program, where they're being family, parents, problems. And we've had people disenroll and then come back when they've settled things in their life. We rarely have somebody, because we do our selection process pretty well now. We've learned who can do this and who can't. We don't have people who we want to disenroll because of their readiness. You have to be ready to do really hard work here. If you're not ready, you don't. It's too hard, because you have to learn the relaxation in the first week, because the second week we begin going into your memories and pulling up your traumas and working on them. So you've got to do your mind-body work and let the CAM people relax you and learn the techniques that we're going to use later, and then you have to be willing to go pull your hooks. We call the points in time where their trauma memories have locked them down, we call them a hook. In fact, we give people once they've gone in there and fixed one of them, they get a goldfish hook of the kind that you see people stick on their cap brims. That's like a badge of honor that you have gutsed it up and gone after one of your trauma memories and done something to it to make it less toxic. Our guys come back with their fish hooks hung on chains and stuff there that they're proud of. But it gives people a talisman to say, wow, you can do this. You don't have to be held hostage by these events from your past.
Who's a good candidate?
I think, well, let me start back with what our ideal candidate is.
Yeah.
Okay, our ideal candidate is a relatively senior soldier who wants to continue their career and is PTSD'd up to the max and is really knows they ain't going to make it unless they do something about it. Something in their life is bottomed them out. They realize their kids are afraid of them, or they're in trouble in their unit, or they realize that they've been trying to drink themselves through this thing and it isn't working, or any of the other ways that people try and deny they need help, and their denial's broke, and then they realize if they're going to stay and make their retirement age or finish their next rank or whatever, they've got to get some help. And that's our ideal candidate, is somebody who wants to salvage their life as a soldier. But we take our criteria is readiness. That is, this is not a good place to start your basic treatment for PTSD. This is not basic training for psychotherapy. It really is not. We want people with some assessment and treatment elsewhere in the system. And we say, give us moderate to severe PTSD, and no active substance abuse. If they're still trying to drink themselves into quiescence, that go over to DSAS and get some substance abuse treatment and get sober and come back. If people are resistant, they're still treatment resistant, still have some denial, that's not going to work. You got to get down in the weeds with your own mind and fix it.
How fresh from battle, then, would someone be?
I really would prefer them to be back for a while in order to get them evaluated by somebody else and evaluated by somebody else in the system, to have a pretty good history of. I've taken people almost off the medevac plane because they were in good treatment with somebody I knew in theater. And so I had a good recommend for them, or we had looked at them beforehand. We knew who they were, but they elected to deploy rather than treat, and then we'd get them when they came back. We've had people that have gone through the program once, deployed, gotten beat up again, and came back for a refresher. But most of the time, our folks are anywhere from years. See, the problem, soldiers are tough. Boy, they prefer to do things themselves. And so we'll get people who have been symptomatic and coping on their own as best they can for 8 or 10 years, from OIF 1. And now it's, that war's over. And now they're going off to Afghanistan. We've got people 6, 7 deployments, and their biggest hook is from the first one. So it may be years from the time when they were traumatized initially, and then it's just been ground in and worsened as they go along.
What do you think is your biggest hurdle at this point? In seeing good results? Is it getting appropriate candidates?
Well, there's two kinds of hurdles.
Okay.
Soldiers in general see mental health as some sort of a failure. There is both self-stigma and the sort of general cultural thing about behavioral health that's out there. I mean, it's Surgeon General and the Chief of the Army they're working on that, and it's so much better than it has been over the history. We're headed in the right direction with that. It was. I'm old enough that I was doing pretty much the same job for the Air Force during Vietnam, and if we got somebody referred, they figured their career was over. They were done just because of prejudice. Now it's better than that. We've got people who are first sergeants someplace else now, or have gone on to advanced positions, have deployed again. So it's not certain. It's a much better environment to work with. But we got to get over self-stigma, right? People have. That's why on day one we say, job one, get over any embarrassment or guilt for being here, right? And they go, what? If you've ever thought bad of yourself, got depressed over the fact that you needed to get here because you got these symptoms, get over it. Talk to your individual therapist, talk in group, do something. Because you got to let that go. This is ordinary for soldiers. And they go, wow, okay. It's not disease. This is a learned problem for you. And you can unlearn it. You can deal with it. So
Is there any one aspect of the program that you think is key, or that?
Yes.
What's that?
Synergy. This is as I started before, this is built on the model that says there may be 15 or 20 components in PTSD. Different pieces of it that apply and that have to be dealt with. We hit it with from all sides, but if we are not staying synergistic in a massed attack, so that all my therapists talk to each other every day. The team meetings twice a week to go over where people are with their recovery and what they need to do later. Do we need to increase their CAM work to get their nervous system quieted down some more so they can tolerate the group therapy? Do they need some neurofeedback get their brain working better so they can remember what's going on? Have they figured out how to use the different tools that we got that makes that things work? It's the synergy, it's the connection of all of the pieces working together and the staging. We've gotten really good at staging things and knowing when to move forward. This little note that I made up there about 3 kinds of trauma, we've started using that model, which we got from the Marines, that PTSD is not one kind of trauma, it's at least 3. It's not official in the psychiatric diagnostic nomenclature, but it's clinically very useful. It's that fitting together and the management of make sure they're using the tools, right? Are they doing the relaxation every day? Are they making progress in decreasing their arousal level? Are they learning the EFT? Have they used their cranial electrical stim device enough? Are they using it like they're supposed to? Are they doing their biofeedback work? And are they working in their individual therapy? Are they working on? We have what's called the top 10 list. The top 10 list of bad stuff you've been through. Are they working on their top 10 list? Have they pulled any hooks? Have they gotten over the isolation hump? Right now, this group is coming to the end of the first week, and they have yesterday, in 3 days, got to oh my God, I'm not the only one, right? To where the group then bonds in because they're all in the same boat. Once that group bonding works, then there's a lot of healing happens out under the shade tree in the front yard here, just from soldiers taking care of soldiers. They give each other advice, they give each other support. I mean, they're used to buddying up and taking care of each other, and they do it real well. If you give them permission and they get it that they're all in this, together.
What about you personally? What do you do? I'm sure that you can't avoid stress in your own life, but you've got all these tools at your fingertips. How do you relieve your stress? What's your strategy?
Well, I have a swimming pool in my backyard, and I'm in there within 10 minutes of getting home if it's warm. If it's warm enough, and right now it's plenty warm enough. My wife is a psychologist and Reiki practitioner, and she ran the first holistic clinic in the Midwest back in the 80s, and we have more supplements and interesting health improvement devices and vitamins, and we eat really incredibly healthy right now. It's we're on it. I mean, we're old. We got to take care of things, so we have to stay in shape. We have to take care of that. I meditate. I do neurofeedback at least every other day. I get to teach relaxation every day, so I'm sitting in here meditating with the soldiers. Right, that gives me a jump start. And I believe that you have to model what you're asking people to do. So I'm all the time tapping, I'm talking. I have 2 acupuncturists that I use in the community here. I use everything that we do here for my own health. I have to tell you though that this is not near as stressful as you might think. I work a lot of hours. But this is the best job I've ever had. This is, my God, if I'd have known this stuff back when I was wringing my hands over the guys we were getting back from Vietnam, not knowing anything to do for them much that worked, that was stressful. We got things that work. And it's
very rewarding, I'm sure.
Yes. This is as satisfying as any work I've ever done in 45 years of doing therapy.
So, soldiers watching this, service members that are watching this, how can they enroll? Can they self-enroll? Do they need to be referred?
Yeah, we occasionally get self-enrollments, but we really prefer somebody to be vetted first through some other source. But we get referrals from the behavioral health people, from the chaplains, from the marriage and family clinics, from the alcohol and drug treatment programs. But we also get it from commanders who've had other soldiers go through. We get it from our graduates. Our graduates, particularly our old sergeants that we've been through here, they'll have some young soldier in tow dragging him in the door, saying, "Come in here and enroll." And we like that because, I mean, they know who's who. We've had spouse referrals. Some soldier's partner will hear about the program and rat them out and drag them over here. And we do get self-referrals. People are in here for some other purpose, and I say, "What's this about?" And then they get excited, and then they come in. Unfortunately, we have a substantial waiting list. I mean, that's just the nature of the business. There are more of them than there are of us.
Can you foresee growing your program, expanding it at all?
I don't know about that. There's at least 3 roads forward coming down over the next 3 or 4 years. They're building a new hospital right behind us here. We don't know whether we'll be there or whether we'll be among the clinics that moves into the old hospital when it vacates, or whether some of the new programs that are slated, that are on the drawing board, will absorb us. It's hard to tell. I really don't. You know, things are in flux right now, budgetarily and militarily, and what's going to happen over the next few years. So I can't predict that. Right now, I can keep doing what we're doing and helping 12 soldiers every 3 weeks and doing good work.